Osteoporosis is thinning of the bones. It's actually a metabolic process which occurs after menopause and when testosterone is declining. So it's an important thing that needs to be screened for in people who are high risk. Otherwise, people can end up with bone fractures. Men and women can be affected by osteoporosis. So 1 in 3 women is affected by osteoporosis and around 1 in 5 men. We also see it in premenopausal women and men. People have had history of intake of steroids, people have had abrupt onset of menopause, surgical menopause, people who have malabsorption and eating disorders. So these patients need to be thought of quite carefully in the screening programs. The causes of osteoporosis are overactivity of the cells called the osteoclasts. The osteoclasts are overactive. So this is the metabolic process that gets switched on in osteoporosis. They're overactive and break down too much bone. The osteoblasts are the bone cells which build up new bone. And these are less active than they should be, and they don't keep up with the breakdown which is caused by the osteoclasts. The whole process is a dynamic process of breakdown and build up, which happens anyway, but it's overactive in the osteoclasts in terms of breakdown in postmenopausal women and people with osteoporosis. Often it's completely asymptomatic, which is why we need to think early about screening. So family history, very important. Did my mother or grandmother, somebody have a stoop of their back? Did they have fractures? So even fractures in the elderly, such as a hip fracture, it's a fragility fracture, they fell on the carpet, it still counts as a risk factor for osteoporosis in the offspring of that person. So the genetics are very strongly predictive that somebody who's had osteoporosis will have offspring with osteoporosis. So that should be a red flag or warning. So often people just notice the first time they have a fracture. So fragility fracture of the wrist. I fell over, it wasn't very much, but I fractured my wrist. Second fractures are in the spine. So people can get a curved spine, stooped forward, and not even know that they've actually had some silent wedge fractures. So it's about looking at the spine, taking a history. Have they had a history of pain? Have they lost height? That's the other thing. So people lose height and think, oh, why have I lost height? That is one of the things that everyone should look at, whether they've got reduced bone density on a bone density scan, if they've lost height or have a fracture. So not curable, but treatable. And what we aim to do with the medications is to prevent fractures, number 1, and improve bone density, number 2. So we can actually visualize this on repeat bone density scans, which incidentally are very safe to repeat because it's low dose X-ray, so you can do it every year if you want to, every 2 years recommended, to see what the improvement in bone density is. And that's what we use to measure whether patients are A, taking it, and B, having a good result. But the medications are incredibly powerful and good. So we have oral medications, which are bisphosphonates, alendronic acid, you take once a week on an empty stomach, first thing in the morning with tap water. And then we move on to, so there's a whole group of bisphosphonates by mouth. There's also injectable bisphosphonates, which are given by infusion once a year. So that means that, you know, patient visits and compliance is always excellent because that's controlled by the doctor of the patient and we know how much has gone into the body. Then the third option, which is used now and can be used by GPs, is injectable Prolia or denosumab, and I use that very widely in my practice. So this is like a flu jab, subcutaneous injection every 6 months under the skin provisos being that patients have normal vitamin D, calcium and renal function tests before they have the injection. But it really is virtually painless, and it's once every 6 months, and it's called Prolia, or denosumab as its generic name. My first go-to about a patient's lifestyle: are they having enough vitamin D? Do they have enough vitamin D? So I always measure vitamin D levels, and we find that most of the population now is deficient. So it used to be thought that 50 nanomoles per litre was perfectly adequate. It isn't, not for osteoporosis, not for preventing fractures. So we have patients who are above 75 nanomoles per litre on the blood test, and if it's not there, we replace the vitamin D with quite high dose vitamin D. Some of the commercial products which are readily prescribed by GPs don't have adequate vitamin D. We also talk in depth about the diet. So are they milk avoidant, cheese, yogurt avoidant? If so, then we might need to add some calcium supplements. But in general, it's the vitamin D that's the most important supplement for people. Otherwise, the medications don't work, and they'll still carry on to get fragility fractures. So these are really important. Exercise, very, very important. So 30 minutes of brisk walking every day, important. If somebody's disabled, if they can't walk, then obviously some movement's really important. Do as much walking as they can, but doing resistance exercises with, say, physiotherapist, personal trainer, to strengthen the muscles in the spine. So that's very important to remember. It's all about muscle strengthening as well, to support the bones and to stimulate new bone growth. But the walking, for those that can do it, that's very helpful. It improves the bone density by activating the osteoblast. So it actually, the percussive movement of the feet on the pavement, let's say, transmits energy up to the femoral neck, the femur, where the hip is, and this can actually stimulate new bone growth. But generally this won't, if somebody's got established osteoporosis, this won't work on its own. It can work in addition to the medications that we give. If someone's got modest or severe osteoporosis, they have to have the medications to fix that, really.